This is, here we go. So we'll start. This is season 2, episode 4 of our faculty development series. And interestingly, I think it's going to be one of the best sessions we've had because it's a topic we're all interested in, which is remediation. How do we remediate clinicians, nurses, doctors, residents, attendings, when areas of weakness are identified? And it's something I've struggled with as a residency director and a clerkship director and a chair. And I don't know if I always did it right. So we thought today we would bring 3 experts in this area together. Adam Levine, who those of you just joining us, has been residency director for 25 years in anesthesia, probably the longest serving residency director in the world, is my guess. Productive. There's probably people who've done it for longer, but no one's been more productive than Adam. And then we have Jared Cutson, who really takes the lead in so many of our educational programs and helps the day-to-day operations of our simulation activities. And Chris Struther, who is also an expert in the use of adjuncts in assessing skills and providing interventions. So with that, I'm going to turn it over to the 3 of you. And I thank you in advance for doing this.
And want to thank you for inviting. Thank you for putting this together. Really appreciate it.
Yeah, and thanks, Andy. And for those of you who I see, I think mostly everybody has answered already. We had a poll up there, and the first question was remediation should be required if a poor outcome occurs in the clinical setting. I'm going to actually end the poll, and hopefully you'll all be able to see the results here. Remediation should be required if a poor outcome occurs in the clinical setting, and 70% of people agree. A demonstration of competency should be required at specific intervals, and 100% of people agree. That's very interesting. And then who should evaluate competency? There's a sort of across the board. We want to actually reissue the poll, and we want to change it just a little bit. It's going to read the same thing, but we want you to insert the word faculty. Faculty remediation should be required if a poor outcome occurs in the clinical setting. Does that change your answer? So go ahead and re-answer these questions, but insert the word faculty. A demonstration of how should be required at specific intervals for faculty. And obviously the last one you don't have to answer, but it's but who should evaluate faculty competency? So you should answer that last one as well.
Jared, could you just add, is that poor outcome felt due to the faculty, or is just a poor outcome? Because poor outcomes happen all the time.
A poor outcome due to some sort of clinical skill or clinical knowledge or something due to that individual.
Eric, you're so meticulous. That's why
I have cardiac arrests that come in all the time. Am I going to remediate someone for that?
Only if you were the one running the code.
Well, I was the one there running it on.
I have a feeling we'll come back to that later in the discussion, but
so I'm gonna stop the poll. We had about 80% or so participation here. We'll look at the results. Did it change? So faculty remediation should be required if a poor outcome occurs in the clinical setting. All right, a little change, not much of a change. A demonstration of how should be required at specific intervals for faculty, and we've moved up to from agree to strongly agree. And then who should evaluate faculty competency? Superiors from within the department, or internal or external independent evaluators. And so this really sort of sets the frame for the discussion today. Chris and Adam and I had a bit of a conversation. We said, let's move away a little bit from the PowerPoint discussion and talks, and let's have a bit of a conversation. So the way it's going to work is I'm going to ask a couple of questions, or a question. We're going to let Adam and Chris share their perspectives on it. And I think at any time, if you have a comment or question or want to chime in, feel free to use the chat, or feel free to take yourselves off of mute. It looks like we have a relatively small group here today. And so the first question, and I think Andy did a pretty good job of introducing both Adam and Chris, but you'll hear a little bit more about their perspectives and backgrounds in terms of remediation from some of these questions. But the first question I had is, how do you identify people in need of remediation? So Adam, Chris, I'm going to throw that to you both, and you can decide who wants to answer it first.
I'll take I'll start, and then the next one, Chris will go first. How's that? So we don't step on each other's toes.
Deal.
So it depends on who you're talking about, and it depends on if it's the residents, it comes from the clinical competency committee and or working directly one-on-one or through emails, texts, any way a faculty member can let me know how underperforming the residents are, because they, it's almost as if they relinquish their responsibility. So, and again, I'm not saying why they're underperforming, I'm just saying that underperformance comes to light. Internal faculty have come to light through the QI process. And if there was repetitive events, repetitive situations, and I'm not saying necessarily the same deficits identified, but a frequency of seeing the same persons, sort of come over the plate in terms of involvement with cases, and likely they themselves, to get back to what Eric said, about whether it was just a bad outcome, since we all have those and it's expected, versus their lack of being able to perform, whether it's knowledge, judgment, skills, management, judgment, etc., led to it. But we've also been a referral from other institutions, and we've been a referral from the state. And some other licensing bodies and credentialing bodies to evaluate the level of the competence of others. Because we do run, I know this wasn't, we run a competency-based assessment program that we provide those, that resource to others in the environment, and other programs have used us, and we strictly focus in on anesthesiologists because that's our skill, and then it has to be specialty specific. We have evaluated competency for people seeking licensure. We have evaluated competency for people that have come to the attention of the OPMC, Office of Professional Medical Conduct, State of New York. And we've also done some remediations for people that were just having difficulties, professionalism difficulties. So they came to our attention through that method.
So could I just to clarify a little bit? So where did you get the referral base for that? Like, talk a little bit more. I think, and you can tell me if I'm wrong, it started because you were doing sort of ongoing training for everybody, and then you got identified as a center for those sort of things, and then people came to you, or it went into...
No, it actually happened earlier than that. So back in 1998, 99, so certainly, I think when few even knew what a simulator was, there was a person who was identified as incompetent by the New York State Society of Anesthesiologists and the Office of Professional Medical Conduct. The question came down to a subcommittee of NYSSA, the New York State Society of Anesthesiologists, and it was a remediation subcommittee. The question was this person remediatable? And so at the time, remediation was determined, or competency was determined, based on normal ways of assessment, which at the time was multiple choice tests and oral board exams. So much like the ABA, the American Board of Anesthesiology, would provide to assess people. Someone had the bright idea, and I believe that at the time it was a person named Ken Abrams, but someone here asked me to become an ad hoc member of this committee to add simulation-based activities to assess the person's competence, and to put them in the ringer, and to add simulation. And to give the punchline, the multiple choice tests and the oral board presentations were so poor, the committee was absolutely confident this person could never be remediated. But interestingly, I gave him 4 scenarios. They were scenarios that I had generated and developed for the very first course, and it was basically studied, the very first simulation activities we did with our first year anesthesia residents when we had the simulator at the VA, and then did it for medical students. 4 scenarios, and the irony is, you put him in the normal environment, he actually functioned okay. He recognized the derangement, he was able to put out the fire and intervened on, to say he would have saved people's lives. He just didn't have a broad differential. And the whole irony is, if without simulation, he would have been deemed unremediatable. But because of the simulated experience, he was actually deemed to be remediatable. I actually don't know the punchline because no one really wanted him to remediate in any of their programs. So he was referred back to OPMC. I don't know if he ever actually saw it. We told my recommendation and the recommendation of the team was that he needed at least 6 months of retraining, like as a resident in a supervised. And that's sort of how it started. And then we became a referral base.
Super interesting. It starts with the one case, and then you gain a reputation, and it becomes a large part of what you've done for a long time.
And this is not something we, you do a lot of because it's still a best kept secret, but it's kind of surprising every time someone reaches out. In fact, New York State just reached out to us maybe about a month ago because we had a series of a series of participants who were deemed incompetent and they were looking to get back. And then we've had just radio silence for a while. And the same person I had dealt with years ago reached out to me again saying, are we still in this game? Are we still providing the service? And I said, yes. And they said that we have someone in the wings waiting to accept the charge to have to go through the assessment. So I want to say drips and drabs.
I'm struggling a little bit because there is identifying a skill or a lack of skill, and then there's the remediation, and I see the ability to identify deficits. Remediation in a practicing physician, I struggle with if that can be accomplished.
So our whole program is predicated on we do have a retraining program for people who have been identified as lack of competence, and it's simulation based, but the simulation based is only a stepping stone to actual clinical remediation. So we use a component of simulation to assess and or develop a formative assessment and then make recommendations, and that person then can use our simulation, or we provide a fellowship for that person to be remediated in an actual clinical environment. But we have successfully remediated people through this process. We have and in fact, so the components of the remediation retraining program is a component of assessment, a component of formative assessment with retraining, and a component of summative assessment. And sometimes they're both. And sometimes the products and or participants have to go through a series of them. Like a person referred to us from OPMC would have a preemptive competency assessment to determine their gaps, a determination if we can remediate, a remediation program, and then a reassessment to see if we fill the gaps.
It seems like the discussion, though, is a remediation for what appears to be physicians who have kind of ongoing and multiple or connected deficiencies. So, you had asked the initial question about a case, and the reality is that there's multiple cases that go wrong all the time, and often it is for multiple reasons, and sometimes it's a knowledge gap about a specific thing or a specific disease process. They may just not know because you know a lot of things, but you don't know everything. Sometimes it's lack of supervision. Sometimes it's, and if you think about the just culture, whether it's egregious versus not, there's so many ways of looking at it that it seems like when you get into the remediation, or at least of what you're doing, my guess is, and I could be wrong, but you probably don't often get referrals from one bad case that one person had versus there's some sort of pattern of issues.
100%, these are patterned. And in fact, I don't think everyone should go through a competence assessment as a baseline to determine any gaps or determine if they need remediation. But we all go through that, I guess, when we do ACLS. So we're constantly evaluating, remediating. It's kind of easy to do that on a global scale because you have specific guidelines and black and white, that, for VTAC, you have X, Y, and Z. And if the person doesn't do that, then there's an ongoing remediation when you just do simulation-based assessment and remediation in terms of just getting people ACLS certified. In terms of the people that show up at our door for assessment and remediation is not just a one-off event. These are patterns, consistent patterns that make them either their license is on the line, they've been reported to OPMC, their credentialing is on the line, something's up. And so no, one event does not lead someone to us. Same thing with our residents. If we don't tend to use simulation-based assessment to assess our residents. Most of the time, it's either some form of mild professionalism issue or a knowledge issue. But when it becomes a prioritization, judgment, clinical aspect, a cognitive plus psychomotor, then we've used simulation to diagnose and attempt to remediate.
I think that's where you're getting a referral from shapes that too, right? You're not getting a referral from a medical board for someone who made one mistake.
Correct.
Right? I'm not getting a referral from the promotions committee at the medical school for a student who had one bad interaction, right? They're in front of the promotions committee because they've had several, and now they come to me and say, hey, this particular person has X, Y, or Z problem. Can you help us sort of work on remediation? Although I do get, personally, on a smaller scale, we get self-referrals for single events, not infrequently. I had a resident, the most recent example, who floated a line, putting a central line and lost the wire for a little bit, like no harm done, but like had one of those moments like, oh my gosh, this could have been a disaster. And they actually individually came to us and said, hey, I had this really scary moment. I'd like to practice. Besides sort of that traditional, the program director gives me a call and says, hey, this particular person's had 2 or 3 of these. Can you work with them? Or, hasn't had a lot of airway experience. I do think we occasionally get a self-referral for these, just to swing back to the original question of someone who just has a particular thing that happened, or they feel like they need to practice once in a while. You get some of those things.
Yeah, so that's the anti-Kruger-Dunning or Dunning-Kruger, whichever you look up, which I don't want to use the S word, but if you're not smart enough to know that you don't know something.
Right.
Chris, does the medical school send you medical students that they would like you to assess if they need remediation? How good are we at assessing that at the senior medical student level?
So they have not. I think it's a real challenge. I think I can tell you, not at the student level, but at the resident level, for example, I worked with a really large group of EM simulationists who were trying to build sim cases to assess core competencies for the residents, and try to look at sort of how do we do some of these other skills, problem-based learning, system-based interaction, those sort of things. And spent a good couple of years building cases and testing them. And in the long run, it was almost impossible to differentiate an intern from a senior resident in a lot of those things. Certain clinical skills, right? Procedural skills, running a code, yes, but the complexities of professional interaction, system-based practice, all those things that go into competencies, it was almost impossible to create a valid simulation scenario to test competence in a lot of those things. It's really challenging, because if you think about one case scenario, and I bring my learner in to do that one case or 2 cases, it's kind of like giving them a test with 3 or 4 questions on it. If you happen to not know 1 or 2 of them, you fail the test. Which is why you need a 50-question test to get an accurate or valid assessment of their knowledge base. To really use simulation to look at competency in general, you need days, you need multiple cases, you need long programs. It's hard to do on a short basis. And it's hard to really establish validity of those things, for an individual learner. Right, on a larger scale, maybe, but one-on-one, it's a challenge to do, which is why I think the referrals tend to come from those more traditional QI committees, promotions committees, groups that have looked at these people over time and said, now we've seen a theme from multiple data points, from patient complaints, from nurse complaints, from test scores, and you put those things together to identify the person that needs remediation.
But to your question, early on, the school was looking at at ways of assessing students and potentially adding remediation. And I actually deliberately stayed away from it. I was invited to bring the concept of simulation for assessment of students. And I really didn't want to go the way of the standardized patient. Because when standardized patients were first introduced by Mark Schwartz, it was something the students liked going to. Then it became an assessment. It was something they avoided like the plague. And that was the last thing I wanted students to feel when they were approaching simulation. I wanted them to be excited about it, not to think that they were being tested, but having the opportunity to be able to explore and experiment and not feel like they're being, under a microscope and making this a regimented environment. So I actually thought this was not a very good environment, or wanted to desperately stay away from that aspect in terms of the medical student assessment program.
So with that, and I know there was a question in the chat. We'll get to that in a second. I want to flip that thought process around, Adam, for a second. You didn't want to go down the assessment route for medical students because you wanted them to enjoy the experience of simulation. But what if you have a person in simulation who doesn't, who you recognize could be challenging or have an issue, whether it's a lack of knowledge, a lack of skill, interpersonal challenges? We espouse in the simulation environment that this is a safe learning environment. We don't do anything, but is our ultimate responsibility to the learner or to the patient that this person's going to go out and interact with? And how do we reconcile, or what do we do with the information that we gain from the simulated environment? If it rises to the level of a patient safety threat?
So are you talking about people that are sent to us specifically to assess and to be remediated? Are you talking about like sort of global simulation? Because the closest thing we have to that experience is our MOCA courses. So and unfortunately, that might sound like lovely chocolate coffee, especially in this nice evening, but that's the maintenance of certification for anesthesiologists. And it's it is but one. It used to be required, but it is but one activity that can satisfy part 4, MOCA part 4, which is practice improvement, is to attend and participate in a 8-hour immersive simulation activity. There is a dilemma because there hasn't come to any conclusion. There is no reporting of performance. There is no assessment of competency. And there, again, just like with Chris, our society and the experts in anesthesiology and simulation have grappled with whether there should be a component of assessment and whether that component could be not only provided basically the user with like a percentile performance compared to their peers based on a series of metrics, whether it's non-technical skills, technical skills, a global holistic evaluation. Again, it gets back to it's very hard to create valid simulations that everyone can agree shows competence. And I think everyone always asks us, and there's a whole consortium of anesthesiologists that sit on how to use simulation to assess, because you can't remediate unless you assess, because you got to figure out what the gaps are, because just because someone sends them to you, there could be deeper seated gaps that have nothing to do with knowledge, or it's how they process or how they prioritize or how they sequence and a lot of people use checklists, and we don't here. When we assess someone, it is a global holistic assessment. And the reason for that is people can buckshot a checklist, and order and priority and actual what you do is as important, if not more important, than getting all this, all the checks marked off. So we basically determine whether someone does or doesn't practice within the standards of care in a simulated environment. And I sort of use the same analogy. Competence is you know it when you see it, just like pornography, right? You know it when you see it. Competence is you know it when you see it. You know when someone's competent and incompetent, and some telltale signs that we have recognized, and it's almost repeated. It repeats itself. If someone who's been practicing anesthesiology for years and years looks uncomfortable near an anesthesia machine and has difficulty sort of using that piece of equipment, that almost is a catchphrase to being universally incompetent in the other things they do. If someone doesn't modify their anesthetic technique, regardless of the patient profile that we present to them, they are deemed, not deemed, it is a reflection of competence or incompetence that rolls over to other things, or there's some just universal things that we witness in a simulated environment. I hate to say it, but when an anesthesiologist uses the term versed instead of midazolam, that seems to corroborate and correlate with a lack of competence as well. I'm sorry if anyone uses that term, but for anesthesiology, it just seems that seems to correlate. And not to be joking, I see people laughing, but these are things that we've witnessed over time. But you're right, there's a real dilemma. If we get it wrong and say the patient's remediated and or okay or not, or competent, and he goes and hurts somebody, now what? Or what if we say he's not competent and he's no longer gainfully employable? We have done both of those things, and I'm fairly confident in our process and in our judgment. There's good construct validity. I know Chris mentioned validity. Construct validity is, do you get what you get? Do you get what you expect to get? And what you expect to get is that third-year residents should perform better than second years, better than first years, better than interns, attendings should perform better than all residents, et cetera. And you can see that in the simulated environment. That's been validated. And when practicing anesthesiologists can't do simulations that third-year medical students can do, that is a real indication that there's some real problems. And we use sort of key standardized approaches to first give a global performance and to even determine whether they are remediatable and if we can fix the problem.
So you brought up earlier this idea of standardized patients and then linking this to simulation, and you didn't want to have an assessment program necessarily because they started to become used as assessment. I want to pose this question to Chris, and Adam, you can jump in here. Step 2 CS has been removed from the process, and that was an independent evaluation of medical students, as you all know. And so does that change our idea about simulation? Like why was step 2 CS removed if we're saying, hey, these are great mechanisms to measure and good opportunities to assess people? What do you think of the removal of step 2 CS? And Chris?
I think that comes back to, I think it's construct validity, I think is what you were just talking about, right? This was an assessment that was made of an idea to generate sort of basic clinical skills and interactions, but it was, had a lot of subjectivity to it. It had a lot of variability to it. I think schools found that over time, it, two things is one is it didn't necessarily reflect actual performance elsewhere, meaning wasn't necessarily measuring what they thought it was measuring. And I do think there was some discussion around did people from, people with a second language, people from different backgrounds and different training, was it unfairly sort of biased towards one group or another in the way that it was assessing and measuring these things? Your interaction with somebody culturally is a little different. It might get read as not handling the clinical skill or the interview well. So I think it was a combination of some thoughts around whether it was one sort of unfair to certain groups, but also I think more so, was it really measuring what they thought it was measuring, and was it a reliable test? And if it's not reliable or it's not valid, then there's no reason to do it.
And not being an expert in standardized patients, but the original standardized patient experience, or certainly when it was a test, was part of the ECFMG. So it was a language test. And then it only became universal when they got rid of the ECSMG and just turned it to the USMLE. And everyone takes the standardized test. And I thought it was eliminated because of COVID. And they just haven't figured out if they should bring it back, because I think the first data was that there was a 2% failure, like a less than a 1% failure rate, then a 2% failure rate. Then they kept having to up the failure rate to almost seemingly just to justify the examination, as opposed to that they were screening out people who weren't going to be, I don't know what's safe, or or just didn't have the, I guess, the communication skills they were after, because that's sort of what the, you know, because there's limited physical diagnosis, there's limited interventions, and there's limited, you know, and it almost seemed like there was a, that it was a test of endurance. I mean, I personally wouldn't, you know, it wouldn't seem difficult, but I personally wouldn't want to sit on a test. I think one of them started at 3 o'clock in the afternoon and went till like 10 o'clock at night. And you had to see a patient every 15 minutes. I mean, how many of us would really want to do that and feel comfortable, you know, and like I said, it seemed like a test of endurance than anything else.
So Adam, you bring up communication. The question in the chat is, this individual says, I find that professional competence and communication deficits, although rare, are the skills that we find, you know, most lacking. Any thoughts on that?
So again, you know, part of the whole issue in the projection of, I believe that ultimately somewhere along the lines, we're going to all be sitting in front of some of this technology to have to actually demonstrate competence over our lifetime, because there's just so much you can garnish from, you know, multiple choice tests. Obviously, the resource of doing communication through the oral board examinations. Does emergency medicine have an oral component to your board process as well? So that's been held on, and I think for a variety of reasons, because you can really dive into someone's logic and knowledge and how they apply and how flexible in the communication. It's pretty apparent and clear that you can gain a lot about understanding both professionalism and communication in the simulated environment. And so that I do believe that simulated environment is a key. Give an example, we were presented with someone who was a full tenured professor from a local anesthesia department, and he became untenable and couldn't work with the senior residents and the CRNAs, and was difficult, confrontational, and had problems. And part of his problems was OCD and obsessive compulsive behaviors. He actually recognized he was having trouble, and they couldn't fire him. And they tried to go through an educational society in anesthesia, the Society in Education in Anesthesia. They failed in a workshop. And so we brought him in. And it is interesting how people can't change their stripes. So you think if someone's being assessed that they would be on their best behavior. He couldn't. And he made it very clear he didn't respect CRNAs and senior residents, that we asked him to set up for a case. It was going to be an ASA1 for a basic case. And it took him an hour and a half to find all the right pieces of the puzzle, including 3 endotracheal tubes, 3 oral airways, 3 laryngoscopes, 3 of this, 3 of that. And it was really kind of shocking how he couldn't control his innate nature to be obsessive compulsive. When he supervised a CA3, he had to go in and emergently, help a CA3 with the straightforward case. Because the CA3 said, no, I got this. He physically took the CA3, who's a PGY4, for people that don't know anesthesia talk, clinical anesthesia, and physically had to move this person over and sit him out of the way because he couldn't control them. Ironically, when we gave him a fairly neophyte CA1 who was naive for the sickest of sick case, he became competent, he became nurturing, he let them do things that some of our even seasoned anesthesiologists wouldn't. And what we recognized, and we sent this back ultimately, is that he's not going to change. He doesn't respect CRNAs who don't have him work with them. He's not going to, if he feels threatened by the seniority of a resident, he won't work with them properly either, and this attitude will come out. So he should just supervise CA1s and be preceptors for neophyte residents and interns. Translation, the chairman that sent us this person said it was the best money they spent, and it completely fixed him. So you can even ascertain, if you have the skill set, to even figure out what the problems are, because you're immersing them in an environment that we work in. And so I do believe this is a very accurate window into people's actual practice.
Yeah, I think there's a couple things there, right? I think one is we're talking about remediation, right? So there's identification of the problem, and that, like Dr. Levine was just saying, is, you know, rather than being able to actually fix it and remediate that, you found where the lane is and how to sort of crutch them and aid them and put them where, you know, where they can be successful. I'm going to put in the chat, don't everybody click at once, an article. I was looking through things on residency assessment for EM residents, and remediation, where they're basically surveying, you know, who are you remediating, how many residents are you remediating over the last few years, and was it successful? And the long and the short of it is if the resident was being remediated for clinical skills or knowledge, they were remediatable, and they were mostly successful. If they were for system-based learning or practice-based learning or professionalism, they were ongoing remediation or unsuccessful. So these are much harder to, you know, sort of remediate or teach folks. You know, I'm going to post one more when I can get my cut and paste to go here, that I found on residents and faculty for unprofessional behavior. There's almost none of this, particularly in faculty. You know, sort of preparing for this, we found lots and lots and lots of resident remediation stuff. And I think I'm going to steer it a little bit for the last little bit here on faculty stuff, and why there is not so much faculty. You know, like I could ask you know, Dr. Lagome or Dr. Jagoda, if you had a particular faculty member who was identified as having clinical problems or any problems, who would you go to for remediation, right? Who is the Dr. Levine of EM? Like, where do you go to remediate an EM faculty member who's struggling? And I think it's really unclear because there's not a lot of it being done. For a variety of reasons. This one just talks about one professionalism study where they brought some folks in and did people were identified for a professionalism issue. They brought them in with a standardized patient and recreated a similar scenario, videotaped that, and then had those folks watch themselves in that session and do some reflection and some work there. And actually, they think they made an impact, but it was a very specific, very labor-intense one-on-one situation trying to help those people identify that issue. And I think some of it's going to depend on what the issue is. You know, for example, you know, with Adam's particular situation, that person has maybe a little bit different than someone who might have something like just don't realize the way they speak to people. You know, they have a tell-oriented way of speaking that people read as being a jerk when they're really just, that's the way they talk, and they can learn to remediate that. And you can sort of see that and reflect on it, but not all those things are fixable.
Yeah, it's interesting. I would 100% agree with kind of what you said. You know, I have no problem taking someone out of residency who's struggled a little, but tries hard and clearly has shown that they've moved ahead over the time. And you can fix people who are, you know, intrinsically intelligent, but have just struggled if they want to be fixed. But it is so hard to fix someone who has professionalism issues. And of all and I don't have very many, but, you know, if you feel like you're repeatedly doing the same thing over and over again with them, and I think you can generally fix it for a period of time. But it is very, very difficult. And to your question, what I will often do is I will ask the person, you know, you tell me who you want to work with, because what I found, especially with things around professionalism or interpersonal interactions, that if they don't believe the person, they'll go talk to them, but they could care less what they have to say. So I will try to have them pick someone of someone that has some level of seniority that we could would work with. But by far, and when I hire now, I have really focused in on professionalism and interpersonal issues, almost exclusion of, you know, 80%, because if that becomes an issue, you can't get anything else done. It's just over and over again. So I think it's something we struggle with a lot. Luckily, there's not a lot of people like that, but the ones that are take an enormous amount of energy.
Yeah, I think actually at Mount Sinai now, there's an interesting group with Bridget and Shaw's group working on this. I'm going to get the acronym wrong, but essentially sounds like coffee, with, you know, folks with identified professionalism issues, and it's a mentoring system. because it's a long-term, remediation where, you have to spend some time with it. It starts with a cup of coffee, where you sit down with somebody else and says, this is what people are saying about you. This is the perception you have. Let's talk about that, identify it. Someone from outside your department, I would coach someone who's in medicine or in surgery because it's not threatening. It's a different group of people. I had a medical student referred to me for remediation for professionalism. And essentially the plan that the medical school came up with was, they sent him to me just as a role modeling, like spend time with this guy, talk to him about the background, what's going on, how you're perceived, right? You do a little bit of a camera check. This is what people are seeing when you interact with them. And then they had him basically shadow me a whole bunch as a, exemplary, like see how somebody does it a different way. And it was more of a long-term coaching than it was, a training like a procedure where you can come down and I can assess you and I can give you pointers and then we can reassess you. It's a much, much different remediation process and a lot longer and harder to do.
You'd think we would be able to find these personality traits and personality defects in the screening process from early on and avoid them getting into the specialty to start, because these things can't be fixed, because if their parents couldn't fix it, this didn't just spring up right before or while they're residents. They've had these personality defects and characteristic flaws for their life. They managed to succeed despite that because they're bright people. But somehow we should be able to screen and identify them.
I would argue that some of them can be coached and improved upon, right? Some of them are personality styles rather than pathology that have served some people well, right? Sometimes being authoritative and directive and being, putting yourself out as confident and correct and right all the time works in med school when you're on the floors and on the rounds. But when you get into the floor and have to actually interact with, nursing and team members, it doesn't work so well. But you can coach people on some of that. Like, here's the way you say things and how it's perceived. Let's do some feedback and work on, changing the way you interact with folks that don't have the same style. So I think some of that can be worked on to a degree.
I think they're just masking it. It's the same people that act, prim and proper when they're interviewing with Andy, but act like jerks to the administrators and people of what they believe is a lower hierarchical environment or have no influence or not of their peer class, whether it's a PA, a nurse, a BCA. I think these people have innate problems, and you can muscle through it, and we all do, because we all bring them in the office and call them, basically, I'm dealing with a guy who's his own worst enemy, sweetest, brightest, great doctor, but he could be a knucklehead. And I think we've coined it, he's a knucklehead, and he will choose the wrong choice given the opportunity. And it's, the cutting of the corner here. And we've gotten him over the hump because they do grow up a little bit, but at some point he's going to, he's not going to have me supporting him or bringing him in and letting him know. He's going to have the chairman bring him in wherever he lands and say, you're out.
Yeah, and I think that's a big driver, right? Is, adult learners, right, as we all know, are self-motivated, right? If they're not interested in change or don't see it as an issue, it's going to be very hard to make any inroads, which is where I think, some of this is really challenging, like with faculty in particular, is they don't get a lot of that feedback. They don't get a lot of that coaching. The clinical stuff is like, oh, so-and-so, blah, 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 but they don't really get a formal feedback. And it's harder, right? Like, in a resident has that threat of like, oh, I could just toss you. It's much harder to do, I think, with a practicing faculty.
Chris, what we often do is one is just going back to the cup of coffee. By the first cup of coffee, a lot of people change immediately. By the second, a lot of them are like, oh, I messed this up, I'll fix it. If you're in there with your third cup, you'll be in there with your 10th cup. It doesn't change. But what, I think to some extent, what we start to do after the second cup is really start to gather a lot of information. And then we try to give them as much as possible objective, this is what, we did a survey and this is what people are saying, they didn't identify you, but this is you. Or this is, your press Gainies and look at where you are compared to everyone. And it usually, there's rarely like one thing sticks out. And so it usually is kind of a, they may be brilliant, but there's a whole bunch of things. And, going back, it is behavioral or personality issues 98% of the time. It's not competence so much. And I think, this is a tough system. This is a place where you're surrounded by very intelligent people. So the competence rarely comes up as does when there's bad outcomes. Often it's because lack of oversight or supervision or unwillingness to get involved or things like that. So I think that, we do a lot, but I think we start after the second or third time at the most, really start gathering as much data, because it's time to say, I don't think we can coach them through this. And we go out of our way to do anything we can, but I just look at it, if my residency director pulled me into his office or her office when I was, just out of medical school and said, you're messing up on this, you need to fix this, I would be personally horrified and do everything I can. And when their answer is, no, you got this wrong, I'm actually doing this right, you don't know, and then they continue to do it, to me, it's unfixable.
Well, definitely getting the data is important. I don't want to get lost on this, but this is why the ACGME wants the 360s that we don't always do. And it's why we did 360s on our faculty, to try and identify some of this professional communication side. And hopefully we'll start back with the 360s. Two quick questions before we run out of time. One, with aging workforce, starting with me, is your literature looking at assessments of the aging physician and their competencies? And the only other thing, Adam, because I don't want us to end without your reflection, since we have strong CIM initiatives, do your programs generate funding for the department, your assessment programs? And I hate to get down to the dollars and cents of life, but it's a key thing for the clinician educator who has dedicated their life to CIM. Is this a funding opportunity for them to develop these kind of programs?
So I'll answer the first one first. I think there's lots of conversations about what to do about the aging anesthesiologist and whether there is a role for competency assessment and whether someone should be assessed. I think you're always walking the fine line between ageism and safety. And it's pretty clear in our literature that there is a belt, obviously, that those right out are a little less safe than those out 5 or 10 years, and then further out starts getting unsafe again. And so that's pretty clear, and we've seen that in our consortium through an ARC grant assessment using simulation. And we saw that the further you are out, and maybe it's a confounding variable because the further you are out, the less likely you even were exposed to simulation in any way, shape, or form. And there are definitely people, no matter what the story, will never believe or adopt or be able to role play enough to think that simulation is of any value. And some of it is also people that do carry the risk or the vulnerability of not wanting to be found out that they don't know in front of others. So, and all of that has to do with, and using simulation for the aged population, I think, is unfair and relatively unjust because the technology is so geared, I think, more to the young and on some level. Although we have used the technology, but a lot of these were self-referrals for people who have been out of practice for an extended length of time through no fault of their own or through fault of their own, whether they changed careers, early retirement, limited scope of practice, they were in some endo suite and now they want to get back into so we've had remediated people who have been out of practice for over 15 years and are now academic anesthesiologists in practicing. So we have a fairly good track record of taking people who have been out of practice or limited scope of practice, and even people with some blemishes on their record, whether it's chemical dependency or other issues. We've had people that the very first person we assessed was lost their license because of Medicare, Medicaid fraud. Again, ethics of bringing those people back.
Well,
Oh, go ahead, Chris.
Oh no, go ahead, finish your thought.
No, I was going to say in terms of funding and whether these things can generate revenue and whether it's something you can hang your hat on. I will say, and I will always say, that it is to everyone's advantage that anyone in leadership will tell you they're broke and that you never make any money. And so that whether it's at the leadership of Mount Sinai or it's the leadership of the department. So I have never, ever, according to our chairs, ever covered our expenses ever in the wildest dreams, ever. When I know that's bullshit. Oh, sorry, I shouldn't have used that term. And I know that's not accurate. And because I know one year we generated nearly $1 million worth of revenue through HIC grants, through our MOCA courses, through our assessment programs, and through our retraining programs. That wasn't, it's not always a guarantee, but the HIC is dried up, so that's long gone, but as you know, but we had generated a fair amount because we brought all anesthesiology teams to our center. So we were, that was actually not an inconsequential grant for a couple of years. Our MOCA courses, people pay $1,800 when we were full-fledged rolling in it. Before COVID, we were doing 2 courses and we would have anywhere from 10 to 12 participants. So you could do the math. That was at least a $300,000 to $400,000 or $500,000, and we split the revenue with the faculty. And our competency assessments are just shy of $20,000. Our retraining can be $20,000 to $30,000 if people want an assessment plus a retrain plus an assessment. That could be a $50,000 or $60,000 cost. However, we are responsible for our own equipment purchases. We are responsible for our own warranties, which are $13,000 to $15,000 per mannequin per head. And so I can see where there could be I don't have to do such, the budgeting doesn't have to be strict on an annual basis because the funds will always come through from the department to make sure that the simulation center has what it needs to continue because of all the altruistic activities that we do, and that includes all the medical student activities that there's no real funds traveling back and forth, or the faculty development, all the faculty that learn how to teach with simulation or assess with simulation, or that also. So it's part of our mission. So yes, it's possible. I don't think you can say, and it is nice when you can make a shekel with the technology. And there were some years that were better than others. Obviously with COVID, there's not a lot of activity going on, or less activity. We're back, the MOCA game is still back on.
I want to flip the direction and we'll first repeat that last sentence, that the department will always be sure the center has the funding that it needs. Nudge, nudge, wink, wink. But I think, again, it comes back to, if you have an outside reputation where people will come to you, you can create revenue. Or if you're doing grants or those sorts of things that bring outside money, and internally it's very difficult, I think. But I want to swing back actually to this other discussion around age and testing competence, and it relates to John Schimmel put a really good question in here where he is self-identifying himself for remediation because he hasn't intubated very many people in the last couple of years. Yeah, you just did. But I think this was actually a really big thing for us. We did a series of faculty simulations and procedural retrains as bring everybody through for a couple of years, a bit back, and we're starting to renew that again, bringing in this airway course and some other things. I think we've identified it as something to be done, because if you think about the farther out of training you've been, especially working in an academic center, which is what John was posting, the residents do all the procedural stuff and you're supervising them, quote unquote, but you're not necessarily doing it with your own hands. And the longer you've been out, the more that is true. So how do we be sure, simulation part of the answer, of course, but how do we be sure that those folks are up to the skill, both physically, mentally, know the latest techniques, I think, in the literature, there's a little bit of this around faculty remediation where there's a lot of acceptance. Actually, everybody in the first survey, everybody said, yes, we should assess our faculty on a regular basis, right? But when you say like this particular person, because they're so old or had this thing, then it becomes very stigmatizing and nobody wants to do it. So I think the answer is proactive programs for faculty, right? The correct way, I think, to remediate folks as you go is to do it in a proactive manner where everybody comes through in a regular basis and gets to refresh their skills. And I can give you feedback in a safe manner where you can practice with your own hands. And if you don't remember how to tie that chest tube to the chest, I can work with you on it. But nobody's calling Dr. Jagoda to say you're incompetent clinically and threatening your ability to work in the clinical environment. I think, the answer to, making sure your older faculty or your practicing faculty that have been out for a little bit are competent is to create programming where they get an opportunity to get feedback and get seen in a manner that's regular and structured and has some validity to it where you can really see what they're doing. But it has to be done, I think, to be socially acceptable, in a scheduled way. But also just people don't necessarily self-identify well. They'll be like, yeah, I'm great at that. And then you bring them back and they're not so much, right? I think you're better off creating programming, CME, where I just go to New Orleans and sit in a room and, listen to a couple lectures that I sort of understand already, isn't necessarily, making sure that my 40 and 50 and 60-year-old faculty are up to par and really performing at their best. I think they need to practice.
So I will say that I know we're running out of time, but there was a adage from my former chairman, Joel Kaplan, who thought it was truly ideal and advantageous to have at least a quarter of the faculty, if not more, working by themselves on any given day to maintain clinical skills. So that is not replicated in a lot of academic centers, because I know from going from center to center to give grand rounds, they have faculty who have never worked by themselves and would never be allowed to work by themselves, which is kind of shocking and appalling since they're the ones supervising. And just to bring up that simulation was used because we have to recognize that there's going to be new drugs, new technologies, new equipment, new things that happen after the fact, and how then do you become competent in those? And we were involved in when remifentanil, which is can be lethal in the wrong hands, a very rapid on, very rapid off opioid was introduced. The FDA thought it was such a novel drug that they made Glaxo Wellcome figure out how to create an educational program. And they actually, back in 1997, used simulation to teach people how to use this new drug, and went around the country teaching remifentanil on a mannequin-based simulator so that people could learn how to use the technology. I think that was a wonderful model that to allow people to learn a brand new thing that they would never have had an opportunity, as opposed to experimenting on people or learning internally, or at least become the expert that then goes back and teaches others how to use the drug. We're about to have a new drug called remimazolam, which is an ester-linked midazolam, and we're going to have to create those similar things here, because it's also going to be a very novel drug that will come on quick, go away quick, and will act like midazolam, but not, because of its rapid metabolism. So how to create the experts who then teach people how to use the technology, et cetera.
So I want to just, be cognizant of everyone's time. It is 5 o'clock. And one of the last things I just want to leave everyone with, we didn't even touch the surface of the surgical skills arena and the fundamentals of laparoscopic surgery, the fundamentals of endoscopic surgery, and the role that simulation plays in competency and remediation for those areas. But I, want to just thank both Adam and Chris for speaking today. I think this conversation could probably go on for another half hour, 45 minutes. And I know Adam would be happy to take anyone out for a drink who would like to continue to have this conversation. But Andy, I want to turn it back over to you for any last thoughts or any last comments.
No, we covered so many things. It's provocative, definitely for the younger faculty. There's many opportunities here for developing programs. But I think what we've seen also is we don't have a lot of answers, or there's lots of answers to be found. And so this was a first step discussion, definitely one that we need to follow up on and keep it alive. We've done lots of interesting things, whether it's our airway initiatives, our precipitous delivery workshops, where we have identified gaps and have developed interventions. But I'm left with Eric Lagome's comments on addressing the communication and professionalism challenges when they arise. And that's an area for us to continue exploring, because I think that's the hardest to remediate. But this was great. I really, the hour flew by.
Well, and I want to thank Jared for creating the environment and, you know, allowing us to depart from PowerPoint and just having just an open dialogue, which became fun, actually. So I really appreciate it, because, and I hope others on the call did also, but it was fun for me and not have to actually click through a PowerPoint presentation. So thank you, Jared. That was job well done in moderating and planning for this. So thank you.
Totally agree. Thank you so much. I appreciate the format, and to Adam, thank you for being here. It's a real treat to have you with us. And
Always a pleasure. We can do part 2 if you guys like.
Yes, we will do a part 2.
Cool. Thanks, Andy. Can I get 10 times the honorarium?
Don't you worry. I'm on it.
he only promised me 4. So